اوكي. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على خير المرسلين محمد صلى الله عليه وسلم. We are warmly welcome you to our today's Sudanese Society of Breast Imaging Multidisciplinary Team case discussion, which was organized by our society. We are honored to host international breast expert Mr. Omar Abdel Hamid, consultant oncoplastic surgery, breast surgeon, University of Khartoum, FRCS, Ireland, Khartoum Breast Care Center, Royal Care Hospital in Sudan. And also Dr. Hiba Muhammad Usman, subspecialized in breast, body, and emergency radiology, associate professor in University of Calgary, fellowship in Master and Ottawa, staff radiologist at Calgary Hospital. Okay, so our today's objectives include exploring multidisciplinary approach to breast cancer diagnosis and management, sharing the best practice, and fostering collaboration learning. We will enjoy expert presentation, questions and answers, and also the panel discussion. Okay, so the mic is yours, Dr. Hiba and Mr. Omar.
Assalamu alaikum wa rahmatullah, and thank you for having me today. I'll start my talk with the component of multidisciplinary team. Next, please. So the multidisciplinary team is composed of the surgeon, the medical oncologist, radiation oncologist, the radiologist, pathologist, breast care nurse, chemotherapy nurse, and research nurse. Also the radiotherapy nurse. Also in the patient can be treated and taken care of by the fertility specialists, especially in the young ladies that want to conceive, and they can offer them oven freezing. They are managed by the genetic team and oncoplastic surgeon and plastic surgeons, pharmacist and physiotherapist. And also they include the prosthesis implant, and all of us work as a same team in managing the patients. Next, please. So what does the MTB round look like? So I'll take our meeting as example. So our meeting is held every Thursday of the week, and then we got email from the chair of the round. It's either the surgeon arranging that or the nurse navigator that arranging that, having the medical numbers for the patients, the initial, and what is the MDP question, and also what they want us what they want us to review. Like they will ask for radiology review, pathology review, and also multidisciplinary management. So our nurse navigator in the radiology department take care of looking to retrieve all the previous images for the patient and sending to ask for any imaging that the patient had outside our institute. So by the time of the meeting, we will have every image regarding the breast cancer done for the patient. And we will have also the previous CTs and MRIs for comparison. The radiologist will review all the images and then review the pathology and check if the sampling was adequate, check the pathology, radiology concordant, and check the clinical note to answer a specific question that the surgeon need to know. Next, please. Before starting the first case, I will remind everybody and myself to use the ACR BI-RADS lexicon in reporting the breast cases, as is this is the international uh, language of communication, breast description, and giving a BI-RADS to determine the suspicious of the lesion. Next, please. This is the first MDP case. So they send it with the question to review to determine whether this patient meets the criteria for neoadjuvant chemotherapy and consultation. Next, please. So this I will do this case as typical multidisciplinary rounds. So first, the surgeon or the treating physician will take over and present their cases. So they will start with mentioning the age and the clinical finding of the patient. So this is a 35 years old with new diagnosis of invasive ductal carcinoma of the left breast, grade 3. ER positive, PR negative, and hair positive. She had some investigations and opinion from outside Canada. Clinically has T2 mass and has been recommended neoadjuvant approach. And they told her that she need mastectomy, giving the extent of the calcification on imaging. So the reason of we brought this to the multidisciplinary meeting is to check for appropriateness for adjuvant pathway. Next, please. Here we will start with the radiology review. So this patient presented to us with left breast discharge, subareolar lump, and she stopped breastfeeding, unfortunately, just 4 months ago. And they thought that this is a milk globules. Next, please. So we started with mammogram. And this is the routine MLOs of the bilateral breast, demonstrate a extensive linear branching, pleomorphic calcification in the occupying most of the upper half of the left breast and extending to the nipple. So we also look at the ancillary finding. There is no nipple retraction. There is a few prominent left axillary lymph nodes, and there is no skin thickening. Next, please. This is the CC view, and it demonstrates the same. And next is a magnification view, showing the pleomorphic branching microcalcification. Next, please. This is the ultrasound. So the standard of care that for most of the patient, we do ultrasound, and because of, that's correct. It's the most suspicious finding was the calcification. But we are searching now for invasive components. Sometimes we can see the speculated lesion in the ultrasound, especially with the dense breast. Like we can see the speculated lesions better on the ultrasound. On this ultrasound, we saw like dilated retroareolar ducts containing pleomorphic calcification, and like we couldn't see any invasive lesion. Next, please. So we went ahead to do a stereotactic biopsy, and this is the needle going through to the area of calcification, and we put a clip to mark the area of biopsy. Next, please. This came back as invasive breast carcinoma of no special type, invasive ductal carcinoma, grade 3, at least 5 millimeter. There is lymphovascular invasion present, and there is ductal carcinoma inside grade 3 with comedo and comedo necrosis and calcification. The biomarkers was ER positive, the PR negative, and HER2 positive. Yeah, next, please. And like my last comment was to remind the surgeon that this calcification extend and involving the all upper half of the left breast, and the measurement of the area is 9 by 7 by 7 centimeters, because that's very important for them for the decision of next treatment. And now I will give the mic to Dr. Yeah. So what happened? Like after that, we did. They requested a MRI to check the extent of the disease on the MRI, and to see if the nipple involvement. Can you play the video, please, Nihat? ما بتقدر تعمل له بلاي؟
بريس داون يعني في الايمج
على
نفسها،
الايمج نفسه.
على الايمج نفسها، على تحت الايمج تحت بتلقي ايوه، على الفيديو بتلقي كده بلاي، نقطة تو بلاي. لا، في الفيديو الأول، الأولى، بس اضغطي على الايمج بتظهر لك الحتة بتاعت البلاي تحت تحت. متحركة برا ولا شنو الشاشة؟
هي لأنه أنا I took representative images after, but
لا، هي ما تحرك معك الفيديو يا نهاد.
excuse me، بس هم images مع فيديو.
لا، في فيديو. الأولى فيديو.
الأول فيديو قلت لك. الأول لو ضغطتي
okay.
عليه تحت بيظهر معاكي فيديو، بعد ذاك
تمام.
اعملي بريس بيمشي.
طب let me try to unshare and try. Wait a second.
خلاص إذا ما قدرتي ممكن we can go to the representative images from the MRI.
I'm trying to open it with Canva. Wait a second. بس بيعمل uploading.
يا هبة كنا متوقعين انتراكشن،
طيب
Yeah, بس
ولا
كنت
عشان الزمن
can you
ولا
hear
عشان الوقت؟
can you hear me now?
يس.
Can you hear me?
yes.
طيب okay.
Yes, we can.
You didn't say anything about the axillary lymph node status, did you?
I will say it now in the MRI.
طيب okay.
بيحمل الفيديو يعني هذا ولا شنو؟
نهاد ممكن نرجع
أيوة
للباوربوينت
كده.
and we can do from the still images.
اوكي، هو فتحته في كانفا فيلا share screen again
Thank you.
and then try to open the video.
Okay, we can go to the still images, please.
Okay.
Slide 18. Yeah, so on the still images, next one, please. So there is extensive background enhancement. So when you compare the left breast with the right breast, there is extensive non-mass enhancement in the left breast, and there is few speculated lesions that are suspicious for microinvasion as described in the pathology results. And then there is, next please, there is rounded left axillary lymph node suggestive of metastasis. This is the biggest foci of macroinvasion in the posterior nipple line that is measuring 1.2 centimeters. So in summary, in the radiological findings, we have a extensive calcification occupying the upper half of the left breast, measuring up to 8.5 centimeters with involvement of the axillary lymph node. So I will give you the mic, Dr. Omar, to discuss. Thank you.
Okay. Okay. Well presented. We have a young lady, 35 years of age, with extensive microcalcification. Okay. As you can see, the breast tissue is so dense, and the microcalcification are extensive. The biopsy showed both invasive component and DCIS. In this case, and by the way, the lymph nodes were mentioned to be positive only by radiology. The important thing here is that whenever you hit by your needle, okay, you can pick up some invasive ductal carcinoma. Although it is typical of DCIS, but the invasive component with this picture is a high possibility. I think the decision of being subjected to neoadjuvant chemotherapy is a wise one, okay? Because I consider this lady to be harboring much more than invasive components than we can see. And she is having a hormonal profile which is not in favor of good prognosis. So neoadjuvant chemotherapy may push the borders of positivity and prognosis towards a better one. So As I said, the hormonal profile is not in favor, especially she's a young lady, and she should start neoadjuvant chemotherapy. And regarding the axillary surgery, she can have upfront sentinel lymph node biopsy, okay? And later on, since there is extension of the microcalcification to the nipple area complex, I think she can benefit from what is known as skin sparing mastectomy with reconstruction. She can, of course, this will be determined later by the radiological and clinical examination, and taking the size of the breast, and to see what suits her, whether it is autologous or silicone or prosthesis based reconstruction, or a hybrid, okay, combination of multi modalities in the reconstruction. But really, she's a candidate for neoadjuvant chemotherapy, upfront axillary lymph node dissection, upfront sentinel lymph node biopsy, and later on skin sparing mastectomy and reconstruction. Nipple sparing mastectomy, I don't advise, because the retroaerial area has extensive microcalcification. I hope you heard me, ladies.
Yes, sure. And I
Yes,
do
sure.
agree. The MRI video, it does demonstrate enhancement of the nipple also. So that is, yeah, again, it's the nipple sparing. Thank you, Dr. Omar. And we can open, and can you go 2 slides more, Nihat, please? So I just copied the, so at the end of the multidisciplinary round, the treating physician just write the summary of the discussion and the reason of the review, what is the pathology, and what is the next slide, and what is the radiology findings and the recommendations. So as Dr. Omar mentioned, she is eligible for neoadjuvant chemotherapy. And also, like, I didn't include the images of the PET scan. She had PET scan, and it demonstrate multifocal disease in the left breast with enhancing a level 1 axillary lymph node. And now we can open the floor for discussion. Thank you.
Okay, Dr. Mona is raising her hand.
Okay. Assalamu alaikum, everyone. Thank you, Hiba, for excellent presentation. Thank you, Mr. Umar. Assalamu alaikum, Mr. Umar. Thank you for your input.
أهلا دكتورة منى، الله يسلمك.
مرحبا. Few comments actually, يعني about the case. يعني you are both right. So this is young patient with nasty cancer, which is grade 3, HER2 positive disease, lymphovascular invasion, lymph node involvement. So yes, she is good candidate for neoadjuvant chemotherapy. And we have, as you said, Mr. Omar, to decide about her surgery upfront in view of calcification, extensive calcification. But just I would like to ask Hiba about, because if we are planning to do a mastectomy, we have to have a confirmation from 2 quadrants. Are you quite comfortable this is calcification is all malignant, or no, you can do like at least to have to take a biopsy from 2 quadrants to confirm, yes, all that is malignant microcalcification? This is one point I would like to ask. The second point is the lymph node is biopsied or no, because I guess it biopsied. And how many lymph node is involved, because this is our presentation last month, if everyone can remember. So for the lymph node management in neoadjuvant setting, so we have to biopsy the lymph node to confirm the biology, if this is the same biology like breast cancer, and to put a clip on the lymph node to consider to do less surgery. we're expecting the response to neoadjuvant chemotherapy in this case to be up to 70% because she's HER2 positive disease. For most likely, she might have like complete pathological response. So this is my point. Are you comfortable? And then we can decide upfront. Yes, this lady, she needs a mastectomy because of extensive microcalcification, which is unlikely to respond to chemotherapy. Number one. And number two, clip in the axilla, send her to have the chemotherapy and then reassess after chemotherapy. And if there is a complete radiological response, at least in the axilla, we are not expecting any response in the microcalcification in breast. So we can do what is called targeted axillary dissection, which is just only rather than upfront sentinel lymph node biopsy. So we target the node, we put a clip in the node, and then we do that just to take this targeted node if there is a complete radiological response with few extra. If everyone remember from last month, I talked about targeted axillary dissection, which is completely evidence-based. Thank you.
Thank you, Dr.
Thank you,
Mona,
Ms.
for the multiple quadrant. On the MRI, unfortunately, we couldn't play the video. It shows that there is at least 2 quadrants involved, and with the speculated lesions at 1 and 11 o'clock. That means that there is 2 quadrants that involved, and there is extensive non-mass enhancement in between. That is the DCIS component. And the axillary lymph nodes are also seen on the MRI. There are at least 2 rounded axillary lymph nodes. Those showed also a little bit high avidity in the PET scan, very highly suspicious for malignant lymph node. The patient is already booked for ultrasound-guided
Biopsy
of the lymph node, and we clip all the lymph nodes. Thank you.
All or only one? You clip all in your
like we biopsy only one. I mean, whenever we biopsy a lymph node, we clip that lymph node.
Yeah.
But we do only one. Yeah.
Okay. Yeah, and then we'll come back to do the targeted dissection later if there is a complete radiological response. I mean, so we are quite keen to see the results.
Okay, thank you, Ms. Mona. Dr. Hussein Ali.
Assalamu alaikum.
Thank
Thank you, Hiba, for your nice presentation. And thank you, Mr. Omar and Mrs. Suleiman, for your comment. I totally agree with both of you surgically, but I would like to add a few things. Number one, she's under 40. We expect genetic testing because this will help us to decide the next step in terms of the contralateral breast. So we agree we need mastectomy anyway on this side, but the genetic testing will help us to decide whether to offer risk reducing in the contralateral side or not. This is number one. Number two, somebody might ask if the decision is already mastectomy and we are not expecting the microcalcification to respond. Why are we doing upfront neoadjuvant chemotherapy? Why we don't go directly to mastectomy and then adjuvant chemotherapy? So to start with, there is no survival benefits or difference between adjuvant and neoadjuvant. So whether you give upfront treatment or adjuvant treatment, the survival is the same. However, giving neoadjuvant chemotherapy sometimes help you to de-escalate from mastectomy to breast conserving surgery. This is not the case in this young lady. So why we still prefer neoadjuvant chemotherapy? Number one, this lady, you give her dual anti-HER2 with chemotherapy and you monitor the response. If there is complete pathological response, then she needs to continue with dual anti-HER2. If there is residual disease, she is eligible for Kadcyla, which is Imtansine plus Herceptin. So based on trial that supports neoadjuvant chemotherapy, and we know pathological complete response is a surrogate for better survival. So despite the fact that she is going for mastectomy anyway, we still prefer upfront treatment to monitor for response and to decide what to continue after that, and also to give us some time to get the genetic testing to decide about the contralateral side. One objection with Mr. Omar, I don't agree for upfront sentinel lymph node biopsy. There is no evidence to support that. You either go for clipping the node, assessing the response, and thereafter doing either clearance or targeted axillary dissection, or you decide axillary dissection from the start. But I don't agree with upfront sentinel lymph node biopsy. Thank you.
Okay.
Thank you,
Yes.
Mr. Hussein.
Yeah, you are right. Targeted dissection, yes, I do agree, because I thought that the first the lymph nodes was negative، لكن دكتورة هبة رجعت وقالت لا هم لسه ما عملوا البايوبسي، لكن I do agree on the targeted dissection زي ما قلت وقالت دكتورة منى. طيب بالنسبة للبنفيت نيو ادجuvant versus adjuvant وتكون البيشنت تريتد برايمرلي باي سيرجري، في طبعا a lot of controversy في الحته دي، وفي a lot of studies done، وفي differences فعلا يا دكتور حسين between الستاديز، وفي survivor benefit، و we are dealing here with a patient young lady، وممكن في الغالب يكون في possibility بتاعت micrometastasis. اوكي، دي نمبر 1. نمبر 2 في هسه هي عندها combination of invasive and non-invasive component. فالسرفايفل benefit I think being يعني given الchoice of أو الchoice بتاع النيو adjuvant يعني will help in this condition. لكن زي ما قلت لك فعلا في controversy وفي a lot of papers يعني في الحتة دي في الناس اليونج، لكن definitely overall survival few يعني can be benefited from the neoadjuvant chemotherapy. ده بصورة عامة. يعني هي العملية زي ما بقولوا it's not a problem. You can go for surgery at any time you like. لكن يعني capturing ال circulating cancer cells يعني شوية كده بديها chance إنه تقلل الفرصة بتاعت اللوكال والديستنت recurrences.
True. Yeah, صحيح.
I don't know, I raised my hand, but I
You're
don't know
welcome,
if you have
Ms.
seen
Rabab.
it or not. Okay, Dr. Ramona said that she's asking about the microcalcification. I do agree with Dr. Hiba. Even based on mammography, this microcalcification is highly suspicious, okay? Without any other associated imaging features, it is BIRAT4C, okay? Because of the presence of linear type of calcification, which is highly associated with high-grade DCIS. And it is even extensive, involving, it is spanning throughout the upper half of the breast. And I can also observe a suspicious lymph node on mammography before MRI. You see, and expected to be suspicious also on MRI, okay? And based on MRI, the features also seen extensive, including most of the breast, okay? But regarding the microcalcification not expected to be responding to chemotherapy, I think there is there is a debate in these points. If you remember, I raised questions in the group in the morning regarding the microcalcification, if it is a predictive to evaluation of neoadjuvant chemotherapy or not. And as I understand in this case, they said that it is a HER2 positive case. Yes? Am I right or wrong?
Yeah.
Yes, all right, yes.
Yes, in HER2 positive is exceptional. You see, as we know, microcalcifications, both neoadjuvant chemotherapy might be stable, the same, increasing or decreasing because of the effect of the chemotherapy itself, fat necrosis and cancer necrosis and fibrosis, a lot of changes that might result in progression of microcalcifications, including non-response of DCIS in invasive ductal carcinoma. Also, it might progress. But there are many factors that can result in increasing or decreasing, microcalcification. But in a case of HER2, they found that this is the only subtypes that microcalcifications respond to neoadjuvant chemotherapy and might demonstrate even complete pathological response. But here, good enough, we have even MRI demonstrate multiple findings and can also evaluate for neoadjuvant chemotherapy, and by subsiding of not only the size, but the non-mass-like enhancement and enhancing of these masses, as well as enhancement of the lymph node, might demonstrate complete pathological response, and we hope it will be the result for this patient. Thank you very much.
طيب نمشي للكيس الثاني عشان الزمن.
Just can I
مهندس
mention
عايزة
just
مصطفى؟
one thing, please, Mr. Omar and
تفضلي.
just about the surgical planning and mastectomy and reconstruction. So again, we have to stress in the importance of multidisciplinary meetings. So in this case, before we do the mastectomy and reconstruction, we have to know if there is any prediction for adjuvant radiotherapy, which is likely because he is lymph node positive. So one of the indication of post-mastectomy radiotherapy is lymph node positive. So this, we have to put this in mind if we are planning to do reconstruction, because this is, we have to let the lady know about the detrimental effect of radiotherapy on reconstruction, especially if it is implant-based. So yeah, this is the only point I would like to flag up, and likely there is radiotherapy. I will be a little bit cautious to offer this young lady implant-based reconstruction because of radiotherapy, because she needs a lot of revisional surgery in future. She's so young, so she will live longer if she treated well. So we have to put this in mind. And I might, according to MDT, so we got, you did mention about the MDT setup, Hiba. So we do here in MDT, oncological MDT, family history MDT in UK, family history MDT, and reconstruction MDT. So I will discuss this in oncological and reconstruction MDT. And the oncologist will help us with decision making. So most of the times they will say, because this is nasty disease and we need to crack on with treatment, we don't want to have any complication post reconstruction. This might delay her adjuvant treatment. So they might suggest, but it is a group discussion, they might suggest keep it simple, have simple mastectomy, have the treatment, because oncological safety is more important. I know psychologically it's important for this young girl to have reconstruction. But the detrimental effect of radiotherapy and complications that might delay her adjuvant treatment.
And the genetics as well.
Yeah. So yeah, she can have genetic testing, especially if she has a family history. So genetic testing, she can have it while she's having neoadjuvant treatment. And this, as we said, will help us with decision making about the surgery.
يا خلاص اوكي. النقطة بتاع الدكتورة منى دي الريكونستراكشن والإفكتس بتاعت الراديو ثيرابي ممكن نتكلم عليها بعدين إذا كان عندنا وقت يا دكتورة منى. اوكي.
اوكي.
Yeah.
في عايدة مصطفى، بعد إذنك مس عمر. مس عايدة you are welcome.
السلام عليكم.
عليكم السلام ورحمة الله
السلام
وبركاته.
عليكم.
أيوة سامعينك يا مس عايدة، تفضلي.
أيوة أنا كنت رسلت في الشات يعني الدكتورة أول شيء نشكر دكتور عمر والدكتورة على ال very good choice of a case for presentation. It's a very good case for presentation. And أنا كنت سألت في الشات عن البايرات، يعني it's not mentioned البايرات and the size of the tumor أنا ما عارفة، أنا ما I don't get it ولا it has been mentioned the size of the original tumor and إحنا we are attacking.
So
بعدين
the
برضو
يعني continue please. Sorry.
سامعني؟
Yeah.
the size of the tumor, the size of the primary tumor and the pirates of the tumor and the possibility of marking of the lymph nodes. Did you in your center have the possibility to mark the biopsied lymph node? If you biopsy it, you can mark it to be easy to be detected during surgery. This is one thing. The second thing, the PET scan, what there, because there is suspicious lymph nodes, there is a start of metastasis. There is the result of PET scan. What was the result of the PET scan? The third thing, I agree with Dr. Ghassan. This case, we agree, any calcification in a malignant breast cancer, we took it for granted it's malignant. And in spite of, we might need to do more biopsies and these things, but I don't think the patient might benefit from neoadjuvant chemotherapy. So we are not in a hurry. We can do the surgery. We find the extent of the involvement of the lymph nodes, and then we can decide did she need chemotherapy. As we know, chemotherapy is not without problems because she's young. It might affect her fertility in the future and these things. Thank you so much.
Thank you, Dr.
Ms. Aida.
So for the BIRADS, she is the pre-biopsy BIRADS, it's at least BIRADS 4C, and the biopsy confirmed malignancy, and that's BIRADS 6. The tumor, the calcification area is measuring at least 9 by 7 centimeters, and the lymph nodes were positive on the MRI and PET scan. The PET didn't find any other area of metastasis except for the axillary lymph node. And yeah, that was your questions. Thank you.
I think you have mentioned also, Dr. Hiba, size of one of the enhancing masses, 1.2 or something in the
1.2 in the MRI. Yeah.
Yes, this is the mass, the invasive component. The largest invasive component is 1.2.
Correct.
Okay, Miss Muna was raising her hand.
أيوة نعم. Just I would like to comment. Assalamu alaikum, Dr. Aida. Just would like to comment about your point about upfront surgery. We are giving you adjuvant systemic treatment because of the cancer biology, because of the age. And so we need upfront systemic treatment as soon as we can. So this is the point. So the surgery, and as well, it will help us with downsizing the axilla. There is axillary disease. So if we give new adjuvant, this will help us with downsize the axilla, where we need to do less. We agree, yes, she has to have a mastectomy upfront or before, but as Hussein said, she's HER2 positive, and she will benefit from having a combined targeted therapy. So because in targeted therapy, in adjuvant settings, they don't give everything. They give it in new adjuvant settings. So she will benefit from, massively from double targeted therapy, rather than to have just only one agent at the systemic at the adjuvant setting. Is as I said, is MDT. So again, we have to stress on the benefit of MDT. It's MDT. So we have to discuss this and see with oncology. I don't know if there is oncologists here in the chat, if can give us their opinion, because in this case, I will encourage this lady in this age with this cancer biology to have and lymph node positive to have a new adjuvant systemic treatment. For the fertility, there is a lot of ways to deal with it before even we start the chemo. So they got, like here in UK, I know it's difficult in Sudan, but there is rapid access to fertility treatment to have whatever they want if there is no children. There's criteria, of course, to help them with fertility preservation. So if there is no children, they got rapid access to fertility clinic, and then they will do either oocyte what we call it, freezing, or embryo freezing. But the priority is for her, not for the future treatment, because she will die from this cancer if we leave her without any new adjuvant treatment, systemic treatment. Thank you.
Last participation from Sir Hussein because of time factor.
Okay, so with regard to chemotherapy, this lady 100% needs chemotherapy. The discussion about whether to give it upfront or as adjuvant, this is debatable according to the MDT. If you decide to go straight away for mastectomy axillary node clearance, well and good, and you can give adjuvant chemotherapy. I insist there is no survival benefits between neoadjuvant and adjuvant, but she needs definitely chemotherapy at some point. So in HER2 positive, the indication of upfront or neoadjuvant chemotherapy, either T2 and above, so 2 centimeter and above, or any size with node positive. So regardless of this, the invasive side here, because it's node positive, she is having a clear indication for neoadjuvant chemotherapy with dual anti-HER2.
She's T4, Hussein. She's T4 breast-wise, and lymph node. She's locally advanced, isn't she? So the new adjuvant chemotherapy.
So anything T2 and above, or node positive. So when I find lymph node positive, I ignore the T. She needs neoadjuvant treatment.
Yeah, absolutely. Well, just to mention, because of the cost in Sudan, so we have to put this in two setup. If there is everything is available, this is the standard, or this is the best. But in Sudan, because I know there is a struggle to get to the oncological after war stop, inshallah, to oncological and the cost of oncological treatment. So the mindset is different. So we can think about how we help this lady to have treatment as soon as we can, so she can have surgery if there is a difficulty in getting the service to the oncology treatment, difficult in cost or whatever. Surgery first and go for to have this in adjuvant setting. So it has to be guided by guidelines and by the practice in the local area. But the standard, this is what we're saying. What we're saying is this played definitely for neoadjuvant chemotherapy. But if it's the situation is different financially, cost-wise, whatever, so we can work around that. Because Aida, I know you work in Sudan and you know the struggles, so you push for the surgery first because of all that. This is my I think this is what you meant. But we have to know what is right and then what we can do or to work around
Yes.
the setup.
Yes, this is the point. Did
Yeah.
she need chemotherapy or not? She is going to benefit from chemotherapy or she is going to be harmed by chemotherapy. This is the point. But in Sudan, there is overbanks in some private areas, and there is, and she can use adriamycin. It can protect the ovaries. But the point, did she need it? Is she going to benefit from it?
Yes.
Yes. She needs chemotherapy.
Yes, definitely.
Okay, Dr.
Definitely.
Hiba.
According to recent
I think if we did we the guidelines, how many lymph nodes are involved and how many these results we can know after surgery before.
We have a confirmed lymph node, so only one node positive is clear indication.
And grade, she's young age.
Grade 3, young.
Her HER2 positive, she's lymph node positive. There's lymphovascular invasion, all that.
She has 3, 4, 5 indications for chemotherapy.
May I add something? Also?
The benefit, yes, our guide is the benefit of the patient.
Yes, according to a recent radiological literature, though HER2 positive tumors is the most subtypes associated with microcalcifications, but it is only or the mainly subgroup, okay, that microcalcifications can be considered predictive for neoadjuvant chemotherapy evaluation, and even might demonstrate complete, the imaging can predict complete pathological response.
Okay.
Thank you.
Shall we move to the next patient or what?
Okay. Okay.
So did we know what happened to this lady, or we don't know?
Complete the discussion
Those are
regarding
new
case one
cases.
at the end
We
of
just
the
present them in
presentation.
the multidisciplinary meeting.
Okay.
So we can, next please, Neha. So this patient is an old lady, 85 years old. The question mark, the question from the MTD is to assess for the primary tumor. So she presented with the left axillary mass. Next, please. This is her mammogram. There is a small architecture distortion in the posterior nipple line middle third. There is no skin, there is a minimum skin thickening. There is no other mass or suspicious microcalcification on the CC. Next, please. On the MLO, there is probably, like, we see the lymph node, we don't know. So we did ultrasound. Next, please. So this is the ultrasound. It demonstrates a large left axillary, hypoechoic left axillary lymph nodes. Next, please. So in the report, we measured the largest one, measuring up to 2.7 centimeters and 1.6 centimeters in the short axis. So those are probably metastatic lymph node, less likely reactive lymph nodes. Or lymphoma could be a possibility. That's why with most of the patient with lymphadenopathy without a breast lesion, we do a lymphoma protocol when we biopsy the lymph nodes. And this could be, and we did ultrasound of the whole left breast. We couldn't find any lesion. So we said this could be a metastatic disease from a non-primary. Next, please. So the patient underwent CT scan, and we saw a large left axillary lymph node. This one here. I don't know if you can see my cursor. Next, please. And there is very high level 2 axillary lymph node that is fixed to the chest wall, posterior to the pectoralis muscle. And next, please. So in the CT chest, abdomen, pelvis, we only saw the axillary lymph node, and we also commented about a diffuse skin thickening in the left side. And we couldn't identify any primary lesion on the mammogram, ultrasound, or on the CT scan. So our next guess that we can do MRI for this patient. That's what I recommended on the NTB, but because of the patient age, they said it will not add much, and they. I can give you the chance, Dr. Omar, to discuss what you will do for this patient, and if you can give us your insight about if this patient was young, what you will do also. Thank you.
Okay. Very interesting case, and the occult breast carcinoma will continue to be interesting. طيب now الحاجة فعلا اللي striking إنه البريست tissue is dense for a lady for 85 years lady. يعني يمكن ناس الراديولوجي يكونوا يعني لاحظوا الحكاية دي أكتر مني. I don't know if she is on hormonal replacement therapy or not, because the breast is really dense breast. The management of occult breast cancer يعني is a challenging issue. يعني أنا I don't know زي ما قلت أنت if ال MRI will add something, لكن I think it is worth يعني doing in such cases. أنا في الحقيقة ما داير يعني أخش في المانجمنت طوالي إلا بس عشان أحسن أثبت معلومات معينة. أوكي، إنه we assume إنه this is يعني occult breast cancer، لأنه if otherwise زي ليمفوما أو metastatic carcinoma بتكون clinically and radiologically very obvious، ما بكون في مشاكل كتير. لكن طبعا 20 years ago كان في بيبر اتنشرت في الأوكل بريست كانسر، والحقيقة البيبر دي was handed to me 10 years ago by a Sudanese colleague who works in UK، وكانت بتتكلم عن الأوكل بريست كانسر. فمن البوست بورتم وجدوا إنه 60% of the postpartum cases اللي كان عندهم اوكل بريست كانسر they revealed 60% of them revealed an invasive component موجود في البريست تيشو. فأنا ما عارف هل في تاني studies اتعملت بعد كده ولا لا، I don't know. التريتمنت يعني at that time ولحد وقت قريب كانت كوادرانتكتومي، باعتبار انه الupper outer quadrant هو the most or the commonest site for the presence of invasive carcinomas، و simultaneously they used to do axillary lymph node dissection. بس الحاجة peculiar in this lady is that she is an old lady. بتبقى طبعا ال confirmation of the presence of a carcinoma in the breast هي حاجة very challenging فعلا. فأنا في الحقيقة ما دار أخش في الموضوع بتاع المانجمنت specifically in this lady لحد لما نسمع الكلام بتاع الناس الراديولوجي and how can other modalities help في ال detection of a lesion in the breast. Okay. لكن
Honestly,
أنا
I
ما
don't have anything.
MRI.
That's the only one, yeah.
برفع يدي لكن ما قاعدة تبين.
يدك ما ظاهرة يا رباب، ده ساوين.
والله طوال بدوس على الهاند هنا وبلقاها ما قاعد تظهر، ما عارفة ليه. طيب نحن عادة بتفق مع دكتورة هبة طبعا، لكن عادة قاعدين نعمل كالآتي: we recommend biopsy of the lymph node first. خلاص.
دي
If
ما
it
المفروض
tends to be
sorry ربابا I didn't show you. ممكن يا نهاد تمشي للسلايدز بتاعت البيوبسي. We did the biopsy of the lymph node and we did punch biopsy of the breast also.
لا أنا أقصد إنه يعني في المانجمنت ما دكتور مستر عمر سأل قال يعني الخطوات اللي بنعملها شنو؟ عادة لما نعمل الكونفنشنال ايميجينج وتكون occult we did the biopsy we do biopsy للأكسيلري lymph node. خلاص to decide if it tends to be metastatic or inconclusive, then we proceed for breast MRI. يعني بتفق معهم تماما. The next step is MRI. يعني ال MRI is highly sensitive for detection of occult breast cancer in conventional imaging. لكن في الكيس دي أنا زي شايفة ليا وأظن ذات الدكتورة هبة علقت على إنه في subtle focal area of architectural distortion on mammography.
Yeah. And I asked, yeah, I agree.
I think in
The problem with this
breast,
patient is the age and the clinical situation.
Why the
old,
age is problem, Hiba? Why is the age a problem? Why?
She is already clear.
Why you discriminate the patient according to her age? You shouldn't.
No, because the patient is not surgical patient. That's the
So
she's frail
comorbid.
and
You can say she's comorbid, but
I'm saying that. Sorry for that. Yeah, I'm just saying that because of the age and the clinical condition of the patient, she is not eligible for surgery. So that's why they didn't want to proceed.
But regarding imaging, I think she has suspicious left breast findings, and from the imaging we can raise that probably it is a left breast cancer with metastatic lymph node. Another point, from ultrasound before the CT, the ultrasound demonstrates extensive adenopathy. You see, from imaging, these lymph nodes are malignant lymph nodes. From ultrasound, demonstrate capsular break and extension into the adjacent tissue, expected to be fixed lymph nodes. See? Yeah. It is a high-grade adenopathy. It is not just simple disease. This is regarding imaging. Next step, it will be MRI if the patient can lie prone for MRI. She might not comfortable to do the MRI in her age and comorbid disease. I don't know if she can do it or not, Dr.
She
Hiba.
can't. She can't.
Yeah, expected in her. Yeah, expected. This is a problem usually we faced.
طيب دكتورة بابا دكتورة هبة, what about contrast enhanced mammography? Maybe it will help in this area of architectural distortion.
Yeah, that might. Usually it's more useful with the invasive, like if we have mass, and like if there is mass, we would see it in the ultrasound as well. And the most, the big problem for the surgeon, because it's also not surgical patient, those lymph nodes are fixed, so that they don't want to proceed with anything for her. I brought this case just to discuss the occult cancer in young and old non-surgical patients.
I think, yes, Sarah, I think it might help. You see, she has even tomosynthesis might help in such patients, because there is subtle area of architectural distortion might appear on tomosynthesis, and in contrast enhanced mammography also. هي ممكن ما تقدر ترقد يعني تنام برون على MRI for long time, لكن الكونتراست enhanced mammography يعني she can do it. I think she might help in her case.
What about the density of the breast يا دكتورة?
It is dense, but certain طبعا يعني الدensity دي بتتفاوت, not only related يعني only hormonal therapy, but also يعني certain races.
Racial, genetic.
Yes, It can be racial يعني.
ايوه
they have dense breast.
اوكي. ما ممكن ده يكون الريزون ذاته يعني the reason behind not being يعني evident clinically or radiologically ممكن.
Correct. Yeah, correct.
والله لا this is heterogeneously dense breast. I think tomosynthesis is beneficial in such type of breast.
طيب هسه يا دكتورة هبة ما في أي طريقة يعني for surgery for this lady she is comorbid قلت لي أنت صح؟
Yeah. They will not be able to do it. And this mammogram was tomo also. They couldn't see anything on the tomosynthesis.
أنا عندي حاجة very genuine بيخلوهم إنه هي يعني not to be touched. أيوه خلاص أوكي تمام.
Excuse me, Mr. Hussein, you have 1 minute.
Okay, so MRI and CAM, my comment for the assessment. And I totally agree with Mr. Omar with regard to the start of how to analyze the primary treatment for the breast. Because between 30 to up to 60% will be having primary breast cancer, even if it didn't show in any modality of treatment. So are we going to have a discussion separate for the treatment?
No, you go ahead. What you will do for occult primary?
So historically, it started by observation, and the outcome was doom and gloom. So observation is not an option. Then the second step mentioned already by Mr. Omar, which is quadrantectomy, and also the outcome is not acceptable. So currently you have two options, either mastectomy
or radiotherapy,
and the pathology slice will be around 2 millimeter. And in this case, in up to 1/3, you will find the primary in the breast. If the patient doesn't want to go for a mastectomy for any reason, then whole breast radiotherapy will be the other option.
Yeah.
So observation is not acceptable, quadrantectomy is not acceptable. The only two acceptable options is either mastectomy or whole breast radiotherapy.
Right, I agree, Hussein, but observation is it can be. Sorry, just observation it can be in addition to radiotherapy or mastectomy. MRI is important, as everyone saying, mastectomy or radiotherapy to the breast or observation. But observe for a long time. You bring her for 10 years for follow-up. So this is what I wanted to say. And for this lady, so if she is comorbid and we need to know about her, the biology of the cancer, it's hormone sensitive, she can just have endocrine treatment. If she is triple negative or HER2 positive, she sent her to oncology, either to give radiotherapy to the axilla or gentle, something systemic. But we need to know the biology. You didn't mention HEPA biology. If her ERBR positive luminal A cancer, she just can have endocrine. If she can have surgery, if she's not fit for surgery.
Here is the pathology result.
Yeah.
Where is it? I can't see.
This is it.
Time's up, Ms. Mona.
Adenocarcinoma.
Thank you.
What is the receptor? Any receptor, ERBR, HER2? I can't see.
No, I don't think that they did the receptors on the lymphoma.
It's important because it's
yeah, it's receptor negative. Oh, this one.
Negative. This is the skin. There's a bunch of biopsy.
The prior slide, please.
Negative. Positive for
estrogen receptor, yes, estrogen receptor here.
Negative.
Negative.
Yeah, just send her to oncology. They need to give something if she's not fit for any surgery. If she's fit for surgery, she needs axillary clearance, and as we suggested for the breast, either mastectomy or no radiotherapy or observe.
Okay.
Which
observation is no longer accepted, Mona.
Sorry?
Observation is no longer accepted.
mastectomy or whole breast radiotherapy?
Yeah, well,
I will
Thank
send
you
it in the
both.
chat.
okay, okay.
Thank you, Ms. Muna. Thank you, Mr. Hussein.
معلش يعني مستر عمر مس منى and دكتور حسين all of you نحن لسه ما فهمنا يعني إذا هي ما comorbid how you are going to treat such patient.
طيب إذا كانت ما morbid this is specifically يعني this lady تتكلم عن الليدي دي ولا generally؟
أيوة الليدي دي أيوة عايزين نعرف التريتمنت أو المانجمنت of her.
طيب okay طيب she has to has a very clear picture about the disease والpossibilities كلها okay. She had to be thoroughly investigated to exclude the other sites of primary, okay? And she has to know well that we are dealing with an occult carcinoma, a carcinoma which after the surgery could be there or it could not be there. Okay, لازم تكون عارفة المعلومة دي كويس خالص. تمام؟ طيب في الاوبشنز بعد كده في الاوبشنز في الام ار ام modified radical mastectomy اوكي. وفي طبعا زي ما قالت الدكتوره منى الايدج is not a contraindication for reconstruction. ممكن نعمل لها mastectomy plus reconstruction. يفضل انه يكون skin sparing mastectomy with autologous reconstruction ممكن. اذا في possibility بتاعت راديو ثيرابي برضه ناخد في الاعتبار الكلام اللي قالته منى قبل الكومبليكيشنز ولانه برضه ممكن السيليكون امبلانت مع الراديو ثيرابي بيجي حاجه يعني عادي يعني ما في مشاكل. ويعتمد طبعا ده بيعتمد على السنتر المريض اللي بيتعالج فيه. يعني الراديو ثيرابي في السودان is a real challenge for the cosmetic outcome of your surgery. ما زي مثلا حتة تانية مثلا ألمانيا فنلندا وكده where we can see a much newer modalities of radiotherapy. Anyhow MRM mastectomy with reconstruction
هتبدو بنيو adjuvant in her case.
No need for neoadjuvant chemotherapy.
بالرغم من الادفانس ادينوباثي وكده.
طبعا زي ما قلت لكم قبل كان زمان بيعملوا الابر اوتر كوادرنت اكسيجن بلس اكسيلري ليف نود ديسكشن، لكن برضو بقت كمان يعني لقوا في حالات بتحصل فيها ريكرنس وكده حاجات كثيره، فبقت تتأثر الاوبشنز يعني محصوره في الماستكتومي. لكن طبعا اهم حاجه انه البيشنت تو بي فيري ويل كونسلد اوكي، والكونسنت يكون فاهم الاجراء اللي حيتعمل له وكده.
هي البيشنت دي اكسبكتد انها لو عملت كونتراست ستاديز انها تبين، لانه في سطل فايندينجز في الماموجرافي.
هو طبعا
في الابر سنترال بريست
البوتوم لاين طبعا في الاوكلت بريست كارسينوما انه it's going to be occult بالرغم من كل الراديولوجيكال ستاديز اللي بتعمليها.
Yes, you are right. I agree with you. لكن قصدت لك in this patient I'm expecting انها يكون عندها يعني اذا اتعمل لها MRI انه تظهر الفايندينجز في الMRI، بما انه في ست الفايندينجز الان على الماموجرافي رغم انه دنس ماموجرافي وكده.
احتمال طبعا.
Okay. Thank you very much.
Okay.
Okay, thank you, Ms. Rabab. Now moving to the next case. دكتورة هبة.
الكيس اللي بعده.
Yes.
لا move the slide I think.
Next.
ايوه.
Next. Yeah. So
this one.
Yeah, this patient is 63 years old, presented to the multidisciplinary discussion for recurrent left breast cancer. Possible to they want to know if it is possible to determine the area size that would require resection, if attempted lumpectomy, and review the pathology from the recent biopsy for extensive underlying DCIS. Next, please. So this patient, I started the images from the beginning. This patient present first time for screening at the age of 63. Next, please. This is her mammogram, and there is leomorphic group calcification in the upper outer quadrant of the left breast. Next, please. So it is, it's in the upper inner quadrant of the left breast, and those calcification are leomorphic, extending in the middle and posterior third. Next, please. Magnification view demonstrate branching leomorphic calcification. Those are very suspicious. So we did stereotactic biopsy. We did ultrasound guided biopsy. So the standard of care, like whenever we suspect that there is underlying mass on the mammogram, can you go back to the mammogram a little bit? Sorry. Yeah, so there on the compression view on the mammogram, there is possible focal asymmetry underneath those calcification. That's why we did ultrasound. The goal of the ultrasound is to identify if there is any invasive component. And can you go for the ultrasound, please? Next. Yeah, next. Yeah. So on the ultrasound, we saw a heterogeneous, ill-defined hypoechoic area, and we can see the calcification inside that area as well. And there are like some newer machines that they have the microbarrel technique that can lighten the calcification for us. Next, please. So this is the area in the anteradial view, and it is still ill-defined with some angular margins. This is very suspicious. So this is at least by BIRAD 4C. Next, please. So we did ultrasound-guided biopsies, as I mentioned, because we tried to target the most invasive component of the lesion, and the specimen and the lesion was at 10 o'clock position, confirmed microinvasion carcinoma, and DCIS. Next, please. The nuclear grade 3, and there is comedian necrosis, no lymphovascular invasion, and microcalcifications was not identified in the sample presented. So sometimes, like what we do in our institute, we biopsy that area under ultrasound. We clip the area to compare the finding on the initial mammogram with the post-biopsy mammogram, and we also X-ray the sample to make sure that there is calcification, and we target the area of calcification as well. So in case we couldn't see a calcification on the sample, the post-biopsy mammogram does not show that we biopsy the calcification. We do also stereo biopsy under mammogram to target the calcification as well. Next, please. So, and so having the invasive component, this is confirmed cancer, and we localized. So back to your question, Doctora, about the clipping in our facility. So we clip using the radioactive iodine clip, and we clip also with magnetic seed. This is the recent technique we adopted last year. So if the patient is going for surgery, so we clip with the metallic normal titanium 3mm titanium clip. That's the least expensive, and then iodine was in between, and magnetic seed is the most expensive. But we shifted to magnetic seed because it has less hazard in both in the radiology department and in the OR, because like the policy is if you lost one radioactive seed, you have to close the area till you have it, till you find it, or till you find it decay. So that's make the magnetic seed is better than the radioactive seed. Also, we used to clip with the localize for the surgery with the wire before, but like we tried to go from the wire because that will need the patient to come in the same day of the surgery, do her wire in the morning, and go to for the surgery in the afternoon. For the seed, radioactive or magnetic seed, you can do it like maybe 1 to 2 weeks before the surgery. Next, please. So this is this was the post biopsy, and there is a clip within the area of calcification. And we measured the whole area of calcification. It was measuring 3.1 by 2.3 centimeters. We localize it with a magnetic seed. Next, please. This is the magnetic seed in the middle of the calcification. And then this is the post-surgical specimen. Next, please. So this was a low positive, low positive, and then next, please. HER positive and PR negative. Next, please. So this is the final post-surgical biopsy. It demonstrates invasive component is 2 millimeters to closed margin, a closed superior margin, and there is high-grade DCIS 0.5 millimeters to the closest margin, that is the superior margin. So that was like positive margins. Next, please. 1 year post-surgery, like every patient with prior breast surgery, personal history of breast surgery, is eligible for annual screening mammogram. And if the breast is dense category D or C, we offer them bilateral screening ultrasound as well. So this patient came for the screening mammogram, and there is a linear calcification in the posterior nipple line, seen best in the MLO. The shape of the calcification look similar to the previously resected cancer. So that was suspicious finding, and we did stereo biopsy for this patient. Next, please. So, and we did, as I told you, we offered them, because she is dense breast, we offered them, and we have finding also, even if it is not dense breast and we have finding, we do ultrasound. So we did ultrasound, and we found speculated hypoechoic mass with angular margin at 11 o'clock position, 3 centimeters from the nipple. So, and that was a little bit posterior to the area of calcification. So what we did ultrasound guided biopsy of this lesion, because we thought that this is most likely invasive component. And we did also stereotactic biopsy for the calcification to determine the size of recurrence. So this is the results of the biopsy. So the ultrasound-guided biopsy came back as invasive ductal carcinoma, as we suspected, grade 3. And then the left breast stereotactic biopsy came as ductal carcinoma in situ, grade 3, with necrosis and calcification. Next, please. The lesions in this, the recurrent lesion in the second year came again as estrogen positive, PR negative, and HER2 positive. So this is the localization. So like in our institute, the standard of care with any stereotactic biopsy, we clip the area because sometimes we do the stereotactic biopsy with a large core needle, usually 10 or 11 gauge. And sometimes you just get all the calcification out. So you need to clip the area to find it in the next, for treatment purposes afterward. So there is anterior, and the anterior small clip, the coiled clip, is the invasive ductal carcinoma, and the posterior coiled clip is sorry, the anterior was the calcification, that's the DCIS, and the posterior was the invasive component.
May you point it? May you point it?
The problem, like I'm pointing, but I don't think that you can see it because I'm not the one sharing.
Because you are not shared, yeah.
Yeah, so it is posterior to the nipple, if you can point it, posterior to the nipple, a little bit down. This coil clip, yeah, correct, this one, thanks. So this is the DCIS, and the posterior one, it is higher and posterior.
The anterior invasive, yes, it.
The anterior was the calcification, was the DCIS.
Okay.
Yeah, and the posterior for, sorry, my bad. So the anterior was those are the surgical clips. Anterior to that, the small dot is the clip for the invasive ductal carcinoma. So
the higher one,
the
Nihat, higher to this. These the surgical clips, the small dot.
Yes. Yes, perfect. Thank you. So we suspect that the disease is extending from the area of invasive to the DCIS, and we measured as 3.3 centimeters. But we requested the MRI to look for any surrounding landmass enhancement. And we did also CT chest, abdomen, pelvis, which demonstrate no metastatic disease. The bone scan was negative as well. So I go back to Mr. Omar Abdelhamid to discuss the management plan. Thank you.
Okay. Again, a very interesting case. I had the feeling that this lady should have mastectomy from the first presentation, considering her age and considering the size of her breast. And in relation to the area of the firstly discovered microcalcification. I think usually if we are going to manage DCIS or invasive carcinoma, both, we have to put in mind the ratio between the area of the invasive carcinoma or DCIS in relation to the size of the breast. So I had the feeling that this lady should have some sort of mastectomy plus or minus reconstruction according to the patient wish. دي حاجة. الحاجة الثانية في الهيستوباثولوجي ريبورت الأول ما كان في منشن أفتكر ليه المارجن ستاتس، مش كده يا هبة؟ ما كان في أي منشن.
لا كان بوزيتيف مارجن. كنت عايزة
كان بوزيتيف؟
بوزيتيف مارجن. فكنت عايزة معلش يا مستر انترستنج كيس فعلا، كنت عايزة أسأل هبة فعلا إن هي بوزيتيف مارجن وانتظروا لحد السكريننج ليه ما عملوا MRI في وقتها، ما طلبوا هي بوزيتيف مارجن.
ما عملوا MRI؟
المفروض يعملوا MRI هنا بعد إذا بوزيتيف مارجن we have to proceed for MRI.
لا هو اصلا لان I didn't get the point، يعني انا ما كنت عارف انه positive margin، لكن طالما انت قلتي كده
positive yeah.
لا طالما انت قلتي كده why they didn't go back for surgery في نفس الوقت.
and I don't know why they didn't do surgery, but they didn't do MRI because it was DCIS, and then they said with the post-operative changes, and sometimes DCIS does not enhance, so they want to wait to do the follow-up. The plan was to do as MRI in 6 months. The patient didn't show up, so she showed up in her mammogram in 1 year.
So the margin was positive for DCIS or for invasive carcinoma?
DCIS was no invasive component in the
Even and even this is more worse. يعني getting
one point, Doctor.
positive margin with DCIS is more dangerous than a positive margin for invasive ductal carcinoma. And this is the reason for her recurrence.
Yeah. I'm sorry, can't be invasive. 2 millimeter invasive.
It is
invasive.
انا اليد عندي ما يعني بأشر باليد وما قاعد تشتغل عندي، معلش اني بدخل فجأة، بس it is grade 3 DCIS. It is a high grade expected to be enhanced, intensely enhanced on MRI. Grade 1, okay, that one expected to be shown to show itself on mammography rather than MRI. But it is from mammography, the calcification, the type of calcification, there are some linear morphology and linear distribution as the metals. Distribution going with high grade. From the imaging is going with high grade and pathologically confirmed the high grade. So expected to show intense enhancement on MRI. And one challenge also, there are secretory calcifications in the background of mammography which make the delineation of exact extent of the calcification is difficult. In such case, this is one challenge. The other challenge in the ultrasounds also presented as a non-mass-like enhancement, a non-mass-like lesion, not a mass-like. And also the delineation is ductal extension. There is some ductal extension going، يعني زي ما تقول كده ده سارحة في التيشو داخلة لجوا. From the imaging expected to have residual findings. يعني محتاجة إنه تمشي beyond the whole extent for the measurements. طيب being high grades وطلعت إنها positive, they have to proceed for MRI and going back for surgery. I don't know what يعني.
عشان كده أنا قلت لك
من الأول يا دكتور هبة.
كان عندي الإحساس إنه هي كان في ميس انتربريتيشن للكلينيكال والراديولوجيكال فايندينجز، لأنه كان أنا عندي إحساس فعلا إنه she was not suitable for wide local excision خالص.
كان
يا مستر معلش يا جماعة، أنا عندي الريزنج هاند برضو ما بيرفع. بس مداخلة صغيرة يا هبة، لو رجعنا للسلايد اللي فيها السبيسمن، يعني بتلاحظي إنه في كلاسيفيكيشن كانت نير المارجن بتاع السبيسمن. ليه ما تراجعت السيرجري immediately interoperatively، مش تطور السبيسمن interoperative؟ يعني لو رجعت للسبيسمن بتلقي إنه في كلاسيفيكيشن نير المارجن كده.
This patient has also like benign calcification was there since 2012. So those in the periphery, like they were there before. The branching calcification was not there before.
No, the suspicious calcification يا دكتورة هبة in the superior margin. I don't know كده راجعي لنا السبيسيمين كانت وين ال positive margin. If it is superior, yes. Here extends to the superior edge. It is clear. ارجع الى السبيسيمين للpathological findings. خلينا نشوفها وين.
The superior margin,
expected superior margin from the specimen as listed. The superior margins is involved.
يعني احنا عندنا كان في المركز لما مستر عمر بيرسل السبيسمن بيكون لسه انتر اوبراتيف وبيكون البيشن مفتوح، فبنراجعها اذا كان في حاجه بيعمل وايد اكسجين.
ايوه بناء
اي
دي
هو في طبعا في تشالنج، لانه زي ما قالت هبه عندها بيناين اكستنسيف بيناين كالسيفيكيشن، ده طبعا بيعمل ديستراكشن للراديولوجيست تو يعني تو من الاكزاكت اكستنت بتاع السسبيشس فروم الباك جراوند بيناين كالسيفيكيشنز. دي واحده
بالضبط كده. مع اللود ذات بتاع الشغل برضه كان
ايوه
يعني.
ايوه.
طيب
لكن من الاول هي هاي جريد واكسبكتد انها ومعاها زي ما قالت معاها asymmetry والبريزنتد في الالتراساوند بين ماس اكستنشن، والاكستنشن حتى الكيرسر بتاعت الميجرمنت it seemed to be less than the extent of the lesion itself. فمن الايمجينج يعني متوقع انه يكون عندها residual in this case، لكن they have to proceed حتى من before هنا والباك جراوند دنس كان يعني من الاول لو عملوا MRI before a surgery for the disease extent it will help يعني.
طيب.
او after surgery والpositive margin is she's a candidate for MRI evaluation.
طيب هسه كده considering البيشنت دي بسيناريوز تاني اذا جات بالريكرنس دي، طبعا الاوبشن يعني زي ما قلت لكم الماستكتومي، وبعد كده بيبقى خيار البيشنت what type of mastectomy. she is young، وبعدين small size breast. small size breast reconstruction فيه سهل يعني ما
She's
بتحتاج.
not young يا مستر، she's 63.
والله
young.
ايوه صح، دي كانت ال 35. صح والله 63 برضه يانج.
She's young، ايوه middle age.
ايوه بعدين الله ايوه definitely she's a western lady من الشكل والدنسيتي بتاعت البريست، لكن anyhow mastectomy is a good choice. اوكي. الحاجه اللي بتقابلنا دائما انه المانجمنت اوف ريكرنت بريست كانسر برضه ده تشالنج. وشال يعني مثلا shall I do مثلا إذا في patient عملت عليها wide local excision أو oncoplastic resection shall I go for يعني conservative breast surgery تاني ولا أعمل mastectomy؟ طبعا زمان كان بيقولوا إنه once إنه في recurrence بعد ال breast conservative surgery we have to do mastectomy. لكن هسه في طبعا a lot of studies اتعملت especially في السبعة 8 سنوات الأخيرة دي. ف you can there is space for redo breast conserving surgery okay in such cases recurrent cases، لكن طبعا عندك criteria معينة. اوكي. البرايمري باثولوجي كان شنو؟ التي ان ام الستيج بتاع التيومر، زي ما قلت لكم التايب بتاع التيومر، الريسبتور ستاتس او البيولوجيكال بيهيفير اوف ذا ديزيز. دي كل حاجات اللي احنا لازم to be discussed في MDT زي ما قلت كلكم. وبعدين to be discussed with the patient، وبعدين يشوفوا الطريقة المناسبة للسيرجيكال مانجمنت، لأنه في role of redo breast conserving surgery in some selected patients.
Can I comment? My hand is up for a while.
last point معلش last point شنو يا دكتور عمر؟
Excuse me.
انه في سبيس للريدو بريست كونسيرفينج سيرجري للبيشنتس اللي عندهم ريكرنس، لكن عندنا سelection criteria very rigid selection criteria. it includes البرايمري staging او primary tumor size، التيومر behavior سوري البيولوجي بتاع التيومر اللي هو طبعا الريسبتورز وكده including KI 61 وكده، البيشنت بريفرنس. اوكي. البيشنت ايج، الفاميلي هيستوري اوف بريست كانسر، دي كل حاجات is going to be discussed in MDT. لانه زي ما قلت لكم في سبيس لريدو بريست كونسيرفينج سيرجري اوكي، لكن طبعا في جايد لاينز معينه. ده بالنسبه للريكرنت بريست كانسر. يعني it's not usually go once recurrent خلاص go for mastectomy، لا، بيبقى في space for redo breast conserving surgery.
Thank you, Dr. Bob. Now, Ms. Muna.
Okay. I think in this case is about DCIS treatment and recurrent DCIS. I think this is all about it. Just my comments about DCIS treatment in contrast to other the invasive cancer, we have to do more surgery. So we need more margins for DCIS. Why? Because for invasive cancer, you can give systemic treatment. For DCIS, you can't. So according to all guidelines, all margins, negative margins, is more in DCIS rather than invasive cancer. So this lady, to start with, she should have more margins or clear margins surgery-wise. So margin is closed or involved, she has to go back immediately to take more margins. This is about the surgery for DCIS. About the technicality of this surgery, as Mr. Omar said, it could be an indication for mastectomy, but I don't know which quadrant this lady has DCIS. Even if it is in one quadrant, still there is a role of breast conservation surgery, even if it is extensive. So if extensive, one quadrant, still we can do breast conservation because nowadays we got the concept of partial reconstruction. So we can do quadrantectomy and we can reconstruct that quadrant with partial reconstruction. This is like completely separate topic, but not all DCIS is indication for mastectomy. So this is about this lady initially. For recurrent, as Mr. Omar, you are quite right. Not all recurrent mean a mastectomy, especially this lady, she didn't have radiotherapy. She declined radiotherapy. So it's still, if she is a little bit bigger size, volume of her breast is bigger, still we can redo wide local excision, especially if she didn't have radiotherapy. Nowadays, there is a discussion, there is a concept of redo wide local excision even with previous mastectomy. But this is still new concept. But this lady, she didn't have radiotherapy. She is a candidate for redo wide local excision with partial reconstruction. Thank you.
Thank you, Ms. Muna. Mr. Omar.
لا كده تمام.
Okay. Mr. Hussein was raising his hand.
I don't want to add anything. All the comments are covered by Mona now. And I do agree with Mr. Omar. This case is a surgical failure. It has nothing to do with the radiology or whether she comes back for MRI or not. This is a surgical failure. She has to go back for more margins.
Yeah, but last comment, all cases is very interesting and there is like excellent discussion. Thank you very much, Mr. Omar, thank you, Hiba, and thank you, the organizer.
Yeah, it's really interesting. Thank you so much.
شكرا للجميع.
Thank you, Hiba. Thank you, Mr. Omar. حقيقة Hiba, يعني you select very, very, very interesting يعني and teaching cases استفدنا منها كثير وتعلمنا منها كثير وما قصرت يا مستر. ودكتورة منى، دكتورة حسين، دكتورة عايدة ودكتورة ماجدولين وكل اللي شاركوا، بصراحة يعني استفدنا منكم كثير كثير جدا. بس عندي سؤال لدكتورة منى. قلتي في الحالة ديت إنها اللهم صل وسلم بارك على سيدنا محمد، قلتي كوادركتكتومي. اوكي؟ طيب سؤالي، إذا الليجن يعني قاعد سنترال at 12 o'clock extending مثلا من medial and lateral, can you do still quadricectomy?
Well, it is in 2 quadrants or 3 quadrants. If it is in the middle and going to the medial.
In the middle.
Yeah, in the middle and going medial and lateral. So this is 3 quadrants. It's not only 1 quadrant. Yeah, correct.
لا ما فهمتك. هي هسه ما قبل علقت لك دكتورة هبة إنه هو medial لكن extended slightly centrally، قالت في الديسكريبشن بتاعها.
I wasn't focusing, sorry. Where is it exactly?
لا my question ما انت قلتوا ممكن تعملوا quadrantectomy.
Yeah.
خلاص الكوادركتكتومي إذا الليجن أقصد لك هي الليجن ده في الميديال لكن extend slightly central.
Yeah.
How you are going to manage?
Well, this is like oncoblastic challenge or oncoblastic skills, because you don't do it by yourself. As I said, we got reconstruction, oncoblastic reconstruction discussion. We take photos for the lady, you present everything, and I have an opinion from everyone whether we can conserve this lady. Is better to conserve and to remove all that and to fill in the area we take with some form of oncoblastic technique, either to recruit some tissue, we call it replacement, or displacement. If this lady is bigger size, for example, and she's huge, we can do what is called mammoplasty. So we can take, we can leave the breast, we take a lot of tissue to treat. So it's a matter of skills and discussion with colleagues.
يعني ما بتسميها في الحالة دي، أقصد ما بتسميها quadrantectomy.
If it is extended into 2 quadrants, no, we can't say quadrantectomy. You can't say quadrantectomy, but we do our best. Rabab, to avoid mastectomy as much as we can. So if there is any way to do breast conservation with any technique, oncoblastic, because oncological surgeon can do mastectomy, can do just wide local excision, but oncoblastic, you got a training for that. So there is a training to be oncoblastic, to find a way to either to replace the breast volume or to displace, to conserve the breast as much as you can. So it depends on the skill of the surgeon who is doing this surgery. If there is no skills, it's better to be a mastectomy rather to avoid. This lady, she came back with recurrence because she didn't have wide margins. So if the surgeon can do oncoblastic procedure, can do oncoblastic surgery, he just to do mastectomy and with or without reconstruction to save her coming back with recurrence. As Hussein said, this lady from first time round, she has to go back to take more tissue to clear the margins.
أيوة، لكن أنا ما أعرف دكتور حسين قال إنه يعني ما أعرف، ما فهمت إنه no need ل radiological re-evaluation ولا إنه to go directly for surgery، ولا قصدي إنه الفول
She was assessed
initially and she went for surgery, and so
there is no place for radiological assessment in between completion of surgery and surveillance. So you go back, clear the margins, and then the surveillance will be and the surveillance will be after that. But you don't assess the margins with MRI.
Yeah, absolutely.
لا we used to assess، يعني we used to assess the margin بالMRI لما تكون المارجن بوزيتيف. كثير من السيرجون بيرسلوا لنا for re-evaluation by MRI عشان نوري لما يدخلوا سيرجري ثاني.
يا دكتور رباب،
في ديبيت هنا. ايوه
دكتور رباب، شوفي الرول عندنا في السيرجري زي ما قال لك دكتورتين. اوكي، positive margin go to theater, go back full stop. دي عشان البيشنت ما يتأخر وما تحصل أي. بعدين شوفي يعني as soon as possible، يعني بمجرد ما ظهرت النتيجة بعد أسبوع 10 يوم الهيستوباثولوجي طوالي مفترض العملية تكون الأسبوع اللي بعده، يعني ما بنتأخر نحن في الحالات الزي دي.
طيب دي في حالة الكلوز مارجن صح؟ دي في حالة الكلوز مارجن،
في البوزيتيف مارجنز. وبعدين
ما البوزيتيف انت عارف حتمشي قدر شنو الاكستند قدر ايش؟
لا طيب اوريكي كيف هو اصلا الراديولوجيكال انفستيجيشنز دي كلها في حته اتعملت لها عمليه ريسنتلي ما بتكون يعني فائدتها كبيره.
صح.
عرفتي؟ بيكون في a lot of edema، وبعدين بيكون في نيكروزيز، وممكن يكون في فات نيكروزيز، يعني ممكن يكون في بلد عرفت كيف؟ هنا طبعا لانه زي ما قال دكتور حسين انه هي فعلا سيرجيكال فيلير، لانه البري اوبراتيف اسسمنت ما كان صحيح. انا اول كلمه بديت لك قلت لك شنو؟ اول كلمه قلت لك انه انا كان عندي احساس، ولو انه دي حاجه يعني شخصيه، انه البيشنت دي should be treated by mastectomy considering the size of المايكرو الاريا بتاعت المايكرو كالسيفيكيشن مع السايز بتاع البرين. لكن اني هاو نحن اذا عندنا بوزيتيف مارجن اوكي، الحل الوحيد انه نحن نمشي للعمليه.
Because you have done your initial assessment, Rabab, radiologist has done the initial assessment and handed her over to surgeon. This lady, she got 3 centimeter cancer.
مرات يا منى، مرات الاسسمنت بتاعنا بكون فيه فولت. خلاص، يعني ممكن ما انت بنيتي الاسسمنت بتاعك على الاسسمنت بتاعنا وكان فيه فولت. خلاص، نحن بنراجع نفسنا. يا راجعنا لك
I don't agree.
لا يا دكتورة، لا، تريبل اسسمنت كلينيكال راديولوجيكال باثولوجيكال، دي الحاجة اللي احنا بنمشي بيها في اي بيشنت.
ما agree with you، انا agree with you يا مستر. خلاص. لكن اقصد انه انا غايته ما عارفه in my practice كثير بيرجعوا لي سيرجون، كثير عملت بريس MRI to evaluate positive margin. فطبعا هو بيختلف من مكان لمكان.
كم بعد الاوبريشن؟ لانه احنا هنا البوليسي بتاعتنا ما بنعمل الا بعد شهرين من الاوبريشن، لانه بيكون الاديما والانهانسمنت والجرانيوليشن تيشو اتس ريلي تاف تو ريد. فما عارفه كم الفتره بتستنوا بعد هنا بعد
لما بنستنى. I agree with you، يعني في within 2 weeks، يعني بعمل في within 2 weeks، لكن شنو هي it is challenging. I agree with you really challenging.
نحن بنستنى
لكن in my experience مرات بلقى residual disease واضح. خلاص، غير الإديمة غير الأشياء دي residual disease.
دي ما حاجات لكن نادرة جدا يا دكتورة. دي حاجات نادرة.
Why it wasn't appearing before the operation؟
ايوه، ما ده معناه برضه في تقصير.
طيب يا دكتور، الآن أنا قلت لها إنها كان في تشالنج. أوريك التشالنج كانت شنو في الكيس دي. أول حاجة عندي باك جراوند بيناين calcification في الماموجرافي. خلاص، it will affect the reading بتاع ال suspicious calcification. خلاص، وقابل لإنه أخطئ في الميجرمنت بتاع suspicious calcification. دي واحدة. في الالتراساوند it was not a mass. البرزنتيشن ما كانت mass. it was a non-mass in term of ductal extension. طيب، فالدكتال الاسبانينج بتاعها غابل برضو لانه يكون فيه شويه ايرور.
يا دكتورة، I totally disagree with you with all due respect. Now this patient is between surgeon and pathologist. Either they clear the margin or go to mastectomy. I don't see any place for MRI or anything. This is between the pathologist and the surgeon, either to clear margin or to go to mastectomy. If they can clear the margin and the pathologist is happy, then she will come back to you in 6 months to 1 year for surveillance. And if we couldn't clear the margin, we go straight away for mastectomy plus or minus mastectomy. In between.
Okay.
سلامات معنا. Do you hear me?
I do agree with you, Dr. Hussein. In case if you are going for mastectomy, there is no role for MRI in this case. I do agree with you. But if you are going to do surgery, يعني تعمل تاني wide local excision or to extend your surgery without going for mastectomy, then here there is a role for MRI.
We do it twice without doing any imaging. We can do re-excision of margin, send it to pathology, and they come back to us again and say it is positive, and we go
and
again
do it
and
again.
we clear it.
Okay, no problem. There are schools definitely. Medicine
no.
Multiple schools.
لا.
هو الحاجة العامة إنه الرول of let us say radiological investigation بعد السيرجري خصوصا البريست. لانه الاركتكتشر بتاعت البريست والتيشو بتاعته بتختلف عن باقي الجسم. لكن في البريست بالذات اليلد بتاع الراديولوجيكال انفستيجيشن از فيري فيري بور. دي حاجه معروفه، حتى يعني ما نحن وي دونت ريسورت تو. انا ما حصل غايته في حياتي مثلا يعني I ask for radiological investigation in a post-operative patient زي دي كده مثلا. ما حصل.
في الفترة اللي قضيتها في السودان دي عندي 2 كيس، واتمنى اني القى الايمج بتاعتها. خلاص ان شاء الله حاعرضها لكم. عندي 2 كيس بوست سيرجري، الاثنين بوزيتيف، الاثنين بروفن تو بي بوزيتيف.
ما هو يا دكتور رباب، ما هو واحده من الاثنين. هي اول حاجه الحاجات بتتكلم فيها دي انت حاجات بتكون رير جدا، وبعدين بيكون يعني في ميس انتربريتيشن زي ما قال لك دكتور حسين ليه هي من الاول ما اتشافت. اوكي، فهي يعني ما حاجه كومون يعني. لكن الحاجه الكومون انه نحن we don't ask for radiological investigation in a post-operative or recent post-operative patient. rather we go for surgery اذا كانت positive margin.
والله نحن ذاتنا we avoid لانها بالنسبه لنا تشالنج. we avoid انه نعمل الايمجنج الريسنت دي، بنهرب منها يا مستر عمر.
ايوه
لكنها واقع، هي موجوده حقيقه.
هي ألذ حاجه شنو احنا لما كنا شغالين في المركز، يعني نحن لو مثلا سهينا كده ساكت وطلبنا حاجه زي كده، ناس الراديولوجي زي كروس الكوليدور يقول انتوا ليه دايرين دي؟ ليه ده؟ ما نقدر نشوف حاجه. يعني هم themselves وهندي ماجورين قاعده في
احنا بنهرب قلت لك احنا بنهرب منها، احنا بنهرب منها.
ماجورين قاعده
بنهرب منها لانها يعني بتصدع بينا وبتحطنا في دايلما يعني.
طبعا
ما يعني تشالنج يعني ما سهل، لكنها في البراكتس انا شخصيا اشتغلتها، والله اشتغلتها كثير يعني ما شويه.
ايوه يبقى
صعبة بس لكن
الحمد لله
صعبة. I agree with you. صعبة خالص، مش صعبة شاي، صعبة خالص.
ايوه الكيسز الليله they are very very interesting cases.
والله interesting
nice cases. ايوه
they raised very important
برضه جميل جدا جدا يعني.
discussion points.
ايوه والله selection nice cases. شكرا يا مستر، شكرا يا هبة، شكرا نهاد.
والله انا سعيد جدا بالنقاش بتاعكم
رجعتونا لصباحات الخميس.
لا سعيد جدا يعني، كان very useful discussion، وانا سعيد جدا بلقائكم، وان شاء الله نتقابل الشهر الجاي ان شاء الله في مساحه تكون اوسع باذن الله تعالى. ولكم جزيل الشكر، والشكر طبعا اولا واخيرا لدكتورتنا الهمامه دكتوره رباب، وبنتنا الهمامه دكتوره هبه. وسعيد جدا برضو عبر الأسير إني أشوف نورس وأشوف منى سليمان وأتعرف بدكتور حسين. أنا I didn't come across surgeons. أنا ما عارفك يا دكتور أنت شغال.
دربته أنا ده ولا دي؟ دربته أنا ودرسته أنا. شفت كيف يا مستر عمر؟
ده دكتور حسين ده؟
أي
هذا الشبلو.
عشان ابقى امسك كويس الدكتوره منى دي.
دكتور حسين اللي معانا نفسه في الجروب، بس انا جاي له ده ضيفته جديد.
لا متنكر
متنكر وانا احترمت نفسي، وانت يعني بتهاجم فينا. انا احترمت نفسي وقلت ده.
لا انا ما قاعد اهاجمك. الجراحين ديل مع بعض مرات كده
شويه
الدم لما يشوفوا الدم.
وانا اقول لك حاجه، انا ما قايل لك جراح اساسا، ما عرفتك بقول مستر وكنت اجي عندك بقول دكتور متحفظه.
انا دكتور متنكر في هيئه اونكولوجيست.
ايوه انا بالمناسبه يعني الاحساس ده يا دكتور حسين في الاول انك انت اونكولوجيست قلت جينيتكس وما جينيتكس، قلت ده ما حقنا.
دي اهميه الام دي تي يا جماعه، دي اهميه الام دي تي. نحن we learn everything from الام دي تي. we learn about the radiology, we learn about the oncology, about everything من الام دي تي.
والله يا منى
من الحاجات اللي لفتت نظري،
اشتغلت بوست اوبراتيف ام ار اي كثير جدا بالمناسبه يا دكتور حسين. لو عنده رول لو ما عنده رول دي ما بعرف. انا السيرجون اللي كان بيرسلوا لي هم مقتنعين انه عنده رول، وكان يعني في كثير من الاحيان بيساعد البيشنت.
طيب من الحاجات اللي لفتت نظري انه في الانترودكشن هبه لما كانت بتقدم في الام دي تي، الناس المسؤولين قالت ريسيرش نيرس. دي حاجة انتباهية جدا بالمناسبة.
Yeah. Yes. Very important. Yeah.
ايوه دي من الحاجات اللي لفتت انتباهي. انا ما كنت عارف انه في حاجة زي كده بالمناسبة الا الليلة بس.
ولا
بيكون
أنا.
موجودين عشان اي عيانه eligible لاني trial they
ايوه
introduce her immediately and they
To be
enroll her
included.
in the trial.
لكن انا ما كنت فاكر انه مدينا تايتل يعني عرفتها. انا كنت فاسيليتيتر بس يعني، لكن ادوها تايتل دي في الام دي دي حاجة كويسة.
يا مستر كيف البنات ما كانوا بيقعدوا
لا ادوها
السيسترات؟
تايتل. لا ادوها تايتل قصدي يعني، عرفتي في الام دي تي.
اوكي.
يلا يا مجدولين، لو عندكم كيسز من المركز يا ريت تحضروا لنا انتوا كمان MDTs. طبعا احنا عشمانين في هبه تواصل لنا بصراحه يعني، لانه
اي والله
يعني
كلنا معك
عندك
أجري.
يعني لانك انت هسه في البراكتس، نحن هسه ذاتنا كلنا بعيدين بعيدين من البراكتس، كان انا مجدولين والشباب ديل. فلو يعني قدمتي لنا تاني وثالث ورابع ان احنا عطشانين جدا جدا، وبصراحه ديسكشن زي ده ما سهل.
كان جميل
اي
شديد
أجري توتالي.
بجد اثريت
يعني
الدسكشن شديد.
والله الكيسز بتاعتك جميله جدا والبرزنتيشن
والكيسز
بتاعك
كلها interesting حلوة شديد.
Yeah, they're very
يا
highly
هبه
selected. Thank
يعني
you.
بصراحه يعني very interesting. انبسطنا شديد جدا جدا وما شعرنا بالزمن والله.
True. Thank you so much يا هبة ومستر عمر. Thank you very much على السيشن الجميل ده، ومستر حسين ومس منى. It was a very nice session. Thank you so much.
انت موجوده؟ انا ما قايلك موجوده يا نورة ذاتي.
قاعدة وصل وين؟
نورة الزمة من النوع البلبت داك، انا عارف عليك كويس.
طيب الكيسز
يديك العافية
كانت جميلة جدا. السلام عليكم.
عليكم السلام.
عليكم السلام ورحمة
الكيسز
الله.
كانت جميلة جدا.
سعيدة تفضل.
لو رجع
شكله عندها مشكلة.
الشبكة عندها كان.
We can't hear you well. سعيدة. Now we came to the end.
تعرف لحد ما ترجع، تعرف يا منى قبل انت علقتي قلتي في DCIS بالذات المفروض تكونوا مور اجريسيف في المارجن، صح؟
Yeah.
يلا بنفس الصورة أنا ما يعني نفس البوينت اللي أنا قلتها، بس قلتها بطريقة تانية. قلت لك إنه الدكتال اكستنشن الكيس دي هي DCIS it is intraductal presenting not يعني usually DCIS ما يعني إلا يكون مثلا rarely to be present as a mass. When we saw a mass we expect that this is an invasive component even if it is micro invasions. Okay. ففي الالتراساوند زي ما هي بعرضتها كانت it was a mass lesion وفي in a term of ductal extension ductal lesion. طيب فالductal lesion جزء منه appear as a hypoechoic وجزء منه لسه بكون يعني ما يعني زي ما تقولي beyond the resolution of the imaging. فدي من الحاجات برضو challenging الممكن انه later انه تلاقي يعني ممكن مثلا الاستادي اتعمل اليوم والاوبريشن اتعملت after 2 weeks. لو اتعمل لها ultrasound after 2 weeks you might see further يعني changes appear خلاص في الفترة الشورت بيريود دي. لأنها it is not a mass it is duct وهي سارحة وماشية through the ducts. عايدة رجعت
سعيدة.
ما عارفة الكلام اتقطع. قلت لك يعني احنا في MDT بتاعتنا في السودان عندنا سايكاتريست وسايكولوجيست يمين، وكان معانا دايتيشن، يعني كان معانا في البريس كلينيك حقتنا دي. إضافة حبيت أضيفها. بالنسبة للكيس الأخيرة يعني لما الباثولوجيست يقول لك انه يعني المارجن يعني نير ولا اتس بوزيتيف مارجن، يعني ما زي ما قال دكتور عمر، ما بتضيع وقت في انك انت تنتظر وتعمل التراساوند وتعمل if it was clear يعني it's a near it's positive ولا it's a near you go for surgery تاني طوالي. الغريب في البيشنت دي هي كانت اصلا كوادرانتكتومي. النو راديوثيرابي is mentioned. انا سالت في الجروب انه فيه she received radiotherapy، يعني لغايه ما تم السنتين she didn't receive radiotherapy.
كان مكتوب في الريبورت.
لا عملوا لها راديوثيرابي دي.
اخذت راديوثيرابي. لو اخذت راديوثيرابي بقى بعد كده ما عندها حل تاني غير الماستكتومي يعني. اوكي.
Now we came to the end. Thank you all.
Thank you very much.
جزيلا لكم.
شكرا دكتورة هبة، دكتورة رباب، دكتور عمر. شكرا جزيلا.
ابتداء من دكتورة هبة والمستر مرورا بكل المشاركين، الحضور على المتحدثين يعني. وشكرا دكتور حسين، مستر حسين، الآن نقدر نقول لك مستر حسين.
ما فرقت. تمام، شكرا.
Thank you Nihad for your effort. Thank you so much Nihad.
You are welcome. You are welcome.
في رعاية الله. السلام عليكم.
Thank you everyone.
وعليكم
السلام
السلام.
عليكم.
وعليكم السلام ورحمة الله. مع السلامة. الله يخليك.
On behalf of Sudan Breast Imaging Society, we proudly conclude our first multidisciplinary team case discussion. We honored by the presentation of the experts, Mr. Omar Abdelhamid, consultant oncoplastic breast surgeon, who is graduated from University of Khartoum, doing FRCS in Ireland, was working in Khartoum Breast Care Center, Royal Care Hospital, and Dr. Hiba Mohammed Osman, sub-specialized breast and body and emergency radiologist, associate professor, University of Calgary, fellowship, MC master, and OTA staff radiologist. From Canada, thank you, Dr. Hiba. Thank you for all the participants for your active participation. Thank you, Dr. Rabab. Thank you, Ms. Aida. Thank you, Ms. Muna. Mr. Hussein. Thank you all for your participation. We look forward.
دكتورة نادية مرسلة لي مسج. دكتورة نادية, are you there?
Yes, can you hear me?
Yes.
I wanted to comment at the beginning when you said that you do radiology for after a pathology report. I can only imagine. Yeah, this is my explanation in Sudan, practicing in Sudan. Probably the report was not complete. I don't know why. Otherwise, a surgeon would send a patient to you after surgery.
دكتورة ايوه يا دكتورة نادية، انت بتسألي انه ليه البيشنت بتجي بعد السيرجري للراديولوجي.
ما نحن في السودان عندنا حاجات it's the other way around because we cannot do it.
ايوه
so maybe they didn't go back to the radiology, to the pathology report, get all the details and they send them to you. Because if I get, as Mr. Omar and Mr. Hussein, Muna all said that if you have a report pathology برضو عايدة معانا في السودان عندك pathology report قال المارجن close or involved انت بترجع للسيرجري. So we are expecting another specimen from that patient.
طيب يلا أنا بالنسبة لي الكيسز اللي عملت فيها MRI خلاص لبوزيتيف مارجنز ما كلها كانت في السودان. In my practice in Saudi Arabia. خلاص.
So it would be interesting to discuss it. Why you had to do it? What's the indication?
يعني أنا بتذكر لحد هسه بتذكر يعني بعض الكيسز جاتوا كان فيها residual خلاص و I'm going to present lectures خلاص regarding لما اتكلم دكتورة هبة ان شاء الله هتشتغل معي في الكورس بتاع الام ار اي، لكن انا هقدم الجزء بتاع الانديكيشنز اوف ذا بريس ام ار اي. لما اتكلم عن الانديكيشنز، هتكلم عن البوينت بتاعت البوست سيرجيكال. خلاص، الايرلي والليت. في الايرلي كيف نحن يعني it is a challenge، لكن كيف بنميز
انا ما في it's definitely a challenge for you يا رباب، لكن انا عايزه اعرف ليه لازم يتعمل.
ما انا هتكلم عن الانديكيشن why it is indicated in such case. خلاص، عشان هسه ما يعني ما ناخذ بها زمن اكثر. هي it is an indication, one of the known indication of breast MRI يعني.
اوكي خلاص، نحن وصلنا كده يا رباب،
بنهرب منها.
اي ورباب نحن وصلنا 2.5 ساعات على فكرة.
We came to the end.
Okay, thank you very much everybody.
تعليق جميل جدا يا دكتورة نادية.
كويس المايك اشتغل أخيرا.
الحمد لله الحمد لله.
Thank you everybody.
Now we can. بعد ما سمعنا صوت دكتورة نادية you can end.
Thank you, Dr. Bob.
Okay.
Excuse me, I didn't see her message in the chat.
لا رسلت لنا في
اوكي.
رسلتها في الاثنين ما في مشكلة. شكرا لك.
Thank you.
Thank
you Dr. Nadia. Thank you Dr. Bob.
رسالة دكتورة نادية. أيوة.
Okay. We look forward for your continued engagement in our upcoming MDTs. Thank you all. السلام عليكم.
مع السلامة.
عليكم السلام.
عليكم السلام.
عليكم السلام.
مع السلامة، في أمان الله.